No fever was noted, however, there was tachycardia, which we may also correlate with the pain. The scale was 8/10. And then hypotension. Shock is secondary to exudation of blood and plasma proteins in the retroperitoneum. However, this was not noted in our patient. And then systemic effects of proteolytic and lipolytic enzymes. So this effect would include the ketonuria noted on urinalysis. And then abdominal tenderness. This sign may be unimpressive compared to the intense pain. So it's one telltale sign of acute pancreatitis if a patient comes in with abdominal pain, which is incapacitating or severely distressful for the patient. However, when you do physical exam, the abdomen seems normal and but only minimally tender. So guarding is more marked at the upper abdomen, which is the location of our pancreas, rather absent, but this is during completely infrequent sign of acute pancreatitis because of the edema of the pancreatic head causing compression in the intrapancreatic portion of the common bile duct. Pulmonary findings, we have atelectasis, pleural effusion, and then we have also, this is only noted in hemorrhagic pancreatitis, we have Collins sign and Turner sign. So Collins sign is the discoloration around the umbilicus, and then Turner sign is the discoloration around the flanks due to exudation of blood. So upon diagnostics of our acute pancreatitis, it's usually diagnosed by the measurement of serum lipase and amylase. Serum lipase is actually the test of choice. However, because this is more sensitive and more specific than amylase, however, it is not available here. That's why we do serum amylase determination. Serum amylase level is typically elevated for up to 4 days. So in acute pancreatitis, there is increased level of serum amylase and lipase more than 3 times the normal range, and then it returns to normal after 3 to 7 days. Over here, at this side of the slide, you can see the serum amylase levels of our patient. Upon the first hospital day, he had an amylase level of 575 per U, and then it decreased to 398 and then to 128. So, as I've mentioned earlier, the preferred test is actually lipase. However, it's not available as much as serum amylase determination. For CBC naman, there is note of leukocytosis and then hemoconcentration with a hematocrit value of greater than 44%. For renal function diagnosis, azotemia with BUN of greater than 22 milligrams per DL is noted if there is loss of plasma into the retroperitoneal space and the peritoneal cavity. We have here other diagnostic exams, serum chemistry. We have hyperglycemia due to decreased insulin release and increased glucagon release. Hypocalcemia due to decreased albumin, which is bound to calcium. So nalulose gihap and calcium due to seepage of albumin. And then we have elevated bilirubin, serum AST and ALT if the cause of your pancreatitis is gallstone obstruction. Elevated serum LDH levels connotes poor prognosis in patients with acute pancreatitis, and then hypertriglyceridemia. ABG hypoxemia was not assessed in our patient. And then we have here abdominal CT scan and sonography for imaging. So your CT scan is helpful in indicating the severity of acute pancreatitis as well as the risk of morbidity and mortality. It aids in evaluating the complications of acute pancreatitis. For sonography naman, it's useful in acute pancreatitis to evaluate if gallstone disease is suspected as cause of your acute pancreatitis. Then we have abdominal radiography. Upon X-ray, the findings may be non-specific. However, it might demonstrate a sentinel loop, a transverse colon dilatation, ileus, ascites, a peripancreatic extraluminal cause bubbles. Upon diagnostics of our patient, the patient was noted to have segmental ileus as well as minimal ascites, which might be caused by your acute pancreatitis. Another sign upon radiography with our acute pancreatitis is the colon cut-off sign. So this is secondary to inflammation extending into the splenic flexure via the phrenicocholic ligament. So there is, nag-cut off an colon. That's why it's termed colon cut-off. So the degree of distension is not as much as through colonic stricture, since much of the small bowel distension of pancreatitis is due to ileus and not really obstruction. For the pathophysiology of our acute pancreatitis, we have duct obstruction, acinar cell injury, and defective intracellular transport as possible causes. But in this case, it is most probably caused by acinar cell injury from infection. So there is enzymes and lysosomal hydrolases which causes activation of the enzymes either intra-acinar cell injury and which then secretes activated enzymes. The activated enzymes would cause interstitial inflammation as well as edema, proteolysis, fat necrosis, and hemorrhage. So proteases for proteolysis, lipase for fat necrosis, and then elastase for hemorrhage. So this would cause now our acute pancreatitis. For the management of acute pancreatitis, analgesics for pain is given. Commonly, actually, in internal medicine is what is one of the best therapeutic or what is the best management for acute pancreatitis done at the ER? And the answer is to put the patient in NPO. This is to rest the pancreas. As we've noted, food would activate pancreatic release of enzymes. And our patient has acute pancreatitis. That's why we put patient on NPO to rest the pancreas. And then we do fluid resuscitation because the most important treatment intervention because it's safe, aggressive IV fluid resuscitation. Our patient presented with dehydration. Aside from metabolic losses, we have caused by vomiting. So we do fluid resuscitation. Antibiotics, prophylactic antibiotics in children are used to prevent infected pancreatic necrosis or to treat infected necrosis. ERCP naman, or severe acute biliary pancreatitis with organ failure and or cholangitis, and then we only resume diet once there is no longer abdominal pain, no note of nausea and vomiting. So in our patient, the patient was given at the hospital ceftriaxone 2 grams every 12 hours, omeprazole 40 mg IV OD, and ranitidine 50 mg IV every 8 hours. So only conventional measures as well as fluid resuscitation was given and then antibiotics as well. ERCP is not indicative. Surgery is only indicated in patients who have diagnostic uncertainty, intra-abdominal catastrophe, which is not related to your necrotizing pancreatitis, and then infected necrosis, severe sterile necrosis, and symptomatic organized pancreatic necrosis. For the prognosis of acute pancreatitis in children, those with uncomplicated acute pancreatitis recover usually within 4 to 5 days. And when the pancreatitis is associated with trauma or systemic disease, the prognosis is typically related to the associated medical condition. For this case, our patient was discharged improved on the 6th hospital day. So for my final diagnosis, this is a case of acute pancreatitis, mild, urinary tract infection, and mild dehydration secondary. So that is all. Thank you.
Okay. So, first, the delivery of the case, medyo maupay hiya kay ang boses ni Claire strong ang iya boses. Except lang ang iya connection ng internet medyo pautod-utod lang yan.
Sorry, Doc.
This is a case of a 9-year-old male. Pero aniya weight was, I think, kung di ako nagsasayip, mga ada hiya 55 kilos.
Ay, obese siya, Doc.
Obese ang pasyente. Then, the patient was actually admitted pediatrics department. Came in because of severe epigastric abdominal pain. And the history that was taken was the patient drink, I think, mga 3 to 4 nga daan na nga gintimpla nga gatas ining what do you call that, mga pagayahin ada na hiya cartoon. So I don't know kung ano nga brand ato nga milk iya gininom, upat ato niya na drink. And after drinking, nag-severe abdominal pain niya. So with that history, so it could be really coming from the one that iya gin take in. So probably the fat content ato nga iya gininom, since it's a dairy product, probably it's very high. Okay? So nag-stimulate hiya in excessive secretions of your pancreatic pancreatic juice. Okay, pancreatic juice. Because your pancreas is both endocrine and exocrine. So when you talk about pancreatitis, you talk about the exocrine and the pancreatic juice. That's why in the evening, it is advised not to eat too much food in the evening. So before mag 6 p.m. supposedly, after 6 p.m. dire ka na pwede mag-take in dinner. So that when you try to sleep, rested nan imo pancreas, dire hiya magsisikretin damo nga pancreatic juice to digest what you eat bilahan dinner. Otherwise, you might lead into what we call as hemorrhagic pancreatitis. Okay, it's sometimes one of the reason after alcoholic binge, mga teenager, after drinking alcohol, then suddenly they're nakakamata or pakakamata, severe abdominal pain, and immediately they die because probably it's a hemorrhagic necrotizing pancreatitis. Okay. Now, there are a lot of differential diagnoses for this one since it's epigastric pain followed by vomiting. So from the medical cases like acute peptic ulcer disease, mga gastritis, mga urinary tract infection, to surgical case, mga gallstone, renal stone, pancreatitis, appendicitis. So everything is possible in the abdominal cavity because it's a Pandora's box. Now you have to try to correlate the history likewise and the abdomen. Since it's a severe abdominal pain, the pediatrician decided to refer this to a surgeon to rule out any probable surgical abdomen or what we call as an acute abdomen. An acute abdomen will be defined didahan manifestation han gastrointestinal tract. I don't know kung nakahimo na may in PowerPoint kay Winston.
Gallbladder daw.
Wins, ada ka pa?
Gallbladder daw.
An pahimong takuhan ano ni an manifestation ng gastrointestinal tract.
Opo dok. May
Oo,
danato daw.
may na to, di ba? Kay iba man nato nga libro. O may mga Schwartz nga libro nga waray nato. So, add to actually to definition ng acute abdomen. If it is a persistent abdominal pain for at least 6 to 8 hours na persistent yan. So, and most acute abdomen leads to surgical abdomen. So when I see the patient in the room, there is still epigastric pain, direct tenderness is still there, but the rest of the abdomen, soft. So what I hear muscle guarding, my bowel sounds, and waray man niya fever, although the CBC showed leukocytosis because probably of the acute onset, I decided to just observe the patient during my first evaluation and my second evaluation. Now, the laboratory turns showed elevated amylase about pamati ko 5,000 ba ito nakaton result mga 5,000.
500 po, Doc. 500.
500. Okay. Now, the normal is 80. So to diagnose acute pancreatitis, an Atlanta classification for pancreatitis, there are only two. It's either it's a mild or a severe type. Now, you only need to have two things. One, if there is a abdominal pain plus 3 times elevation of your amylase, you can say that this is a acute pancreatitis. Or one, there could be abdominal pain, the serum amylase is normal, but on ultrasound, it will show that the pancreas is inflamed. Or during CT scan in adult, there is an abdominal pain, the serum level of your amylase is a little bit high, just above the normal or within normal, but the CT scan will show that the pancreatic organ is inflamed. You can still consider this as pancreatitis during your diagnosis. Now, for the severe type, of course, there will be signs of extravasation of blood. Like if you can see discoloration found in the umbilical area, you call this as colon sign. Now, if there will be bluish discoloration on the flank, on the retroperitoneal region, it's what we call as the Gray Turner sign. Now, sometimes you have Kerr signs. Ano spelling ito in Kerr sign? HR, Kerr sign. There will be pain on the left shoulder, secondary to blood in the left upper quadrant. So, pasok ka, maulol man ang left shoulder. It's a referred pain, the Kerr sign. So this will show some severity. And of course, some will proceed with the Ranson's criteria for pancreatitis. Although they are no longer using the Ranson's criteria, they are more using the Apache scoring. For the Ranson's, it will tell you the severity, it will tell you the morbidity and the mortality. If the Ranson's criteria is more than 4, probably it's more severe. And for the Ranson's criteria, you need to take in a lot of laboratories from your BUN, ano pa tiya? I think creatinine is included, lactic dehydrogenase, I
Blood
think
glucose level.
ano pa to, ang blood glucose level, damot to yan nga.
BUN, Doc.
In fact,
Calcium,
LDH din, Doc.
lactic
LDH, AST.
dehydrogenase. May da ito niya application na da ha cellphone nga imula ikikiin ang result and it will tell you an prognosis and Ranson's criteria. We are actually still using the Ranson's criteria, but for other surgeon they no longer use the Ranson's criteria. They are more dependent on the CT scan. Okay. Now, fortunately for this patient, even though the amylase is very high, by the way, your amylase, the amount of your elevation of your amylase will not tell you the severity, meaning if the amylase is 5,000 or 10,000, it doesn't mean that the patient is becoming more severe. Okay. The elevation of your amylase will only tell you that there is a problem on the pancreas or from other organs that are secreting amylase. So far, the specific here is more of the lipase, but unfortunately, we don't have the lipase in RTR. Now, you also need to know when will the serum amylase elevate from the time of attack. And when it stay elevated, for how many days will it stay as elevated? Then, how many days will it start to decline? Because those are the time that you need to repeat your serum amylase. Okay. And sometimes, from acute pancreatitis, this will lead into when it keep on repeating because the pathology, waray ka control and pathology, and you keep on repeating, this will lead into what we call as chronic pancreatitis later on. And when it leads into chronic pancreatitis, usually the amylase here are already normal. But this will lead into a dilated pancreatic duct. That sometimes the only treatment here is you need to divert the pancreatic flow of your duct to another organ. There are two operations for this one. It's either you cut the pancreatic duct longitudinally. I think the operation here is the puesto, PUEVTOV. Ano pa? So, sometimes the pancreas will progress its severity. If the abdominal pain, because usually acute pancreatitis, 2 to 3 days with conservative management, mag-i-improve hiya. By conservative, nothing per orim so that there will be no food going inside and there will be no stimulation on the pancreas to secrete more fluid. Because the daily output of your pancreas from your bile, from your gastric juice, this will aggravate the condition. Second, sometimes you need to give antibiotics for pancreatitis. And fluid hydration is important. And of course, you have to control the pain. It's either you give the non-steroidal or the more centrally acting opioids to control the pain, because the pain will depend on the individual, whether ano niya pain threshold. And sometimes it can be relieved by just putting a hot compress. A hot compress is enough. The characteristic for pancreatitis is because of the severe pain, they are more relieved when they sit up. So may daya pain, epigastric, then na-sit up hiya para mawara ang pain. While appendicitis naman, they lie down, they do not want to move because every time they move, natatouch ang peritoneum, an inflamed appendix, so causing the right lower quadrant. While gallbladder pain is more of a colicky type, na crampy type, na ul-ul, nawawara, na ul-ul, nawawara. Similarly to your ulcer, these are more of lancerating. It's either before or after meals. But for the pancreas, it's more persistent. Bagaya higin titiros-tiros ang kaulol. Now, dito ang pathophysiology, tutulo man ang gin-describe ni Almo. Ano sa obstructive, pwede secondary to stone or gallstone pancreatitis. Kung an imo gallstone from the gallbladder na nalusad the common bile duct, and you had a common channel pancreatic duct, common channel duct, which connect the biliary and your pancreatic duct. So any problem on the gallbladder will have a problem on the pancreas. Any problem on the pancreas will have a problem on the gallbladder because of the common channel duct. And sometimes they have individual ang nira pagsulod. In children, damo gyud itong mga congenital anomaly and anomaly of the pancreas. I think it will be lectured dito han chapter na han pancreas and mga congenital anomaly of the pancreas. There's a problem with the duct of Wirsong and the duct of Santorini. And sometimes na encircle and head of the pancreas na duodenum to cause intestinal obstruction. So mga obstructive type. And second nga level niya more on mga drugs, virus, bacteria, alcohol, and the last one more about metabolic and iya mga food nga gintake. For patients who are elevated on triglyceride, some of this will lead into pancreatitis. For patients who are diabetic, they also lead into pancreatitis. Kaya nakakamatay naman ang iya mga cells dito pancreas. Now, as much as possible for pancreatitis, we do not want to do any surgical maneuver as much as possible. But if the patient severity will progress and on repeated examination, the patient becomes septic, hypotensive. After the CT scan that showed necrosis on the pancreas, you need to open the patient and do necrosectomy. You need to open the lesser sac, remove all the necrotic materials of the pancreas, and put in multiple drain so that the pancreatic juice that will come out can go externally and will not cause any pancreatic ascites. You also have to understand itong ultrasound. When an ultrasound tell you that there is ascites or fluid in the abdominal cavity, because normally in female, peradto ang peritoneal fluid. Normally
50 cc, Doc.
50 cc. In male, peritoneal fluid
Almost zero.
almost zero. Okay. Now, on ultrasound, when you see fluid, you have to determine whether it's transudate or exudate. And sometimes, most of the time, when the patient when the ultrasonologist will tell you that it's ascites, do you think that it's just a clear fluid? Sometimes they mean that it's blood in the abdominal cavity. For ectopic pregnancy, they will just put it ascites, but actually it's blood. Okay, so you have to interpret the result clinically on the history and on your physical exam to arrive a decision whether you're gonna explore the abdomen or not. And whenever you decide to open the abdomen, there should be an indication or basis why you're gonna open the abdomen, especially if the patient is hypotensive or there are concealed hemorrhoids that you need to immediately. Tawati ko niya akong tabi, ginugutom na. So, nakakawara-wara na tayong signal. And anyway, somehow nakuha ba niyo ini nga case? The case is more about acute pancreatitis. So when you see another patient with these signs and symptoms, somehow may da ka na idea kung how you gonna approach this one. For this patient na discharge namon inihiya, waray kaabrihi, kay pancreatitis manlaya, the patient I think stayed for 3 days. And when we repeat the serum amylase, mga after fifth day, repeated to hiya after discharge, medyo hinay-hinay na pag-ubos aniya serum amylase.